So 9 months ago to the day, the 12 members of the jury first started hearing evidence in the trial of the nurse Lucy Letby. Today we'll see the conclusion of the judge's summing up of the case, after which the jury will retire to consider verdicts on the 22 charges, 7 of murder, 15 of attempted murder. The judge refers to the cases of Child O and Child P, two of 3 triplets born on June 21, 2016 at the Countess of Chester Hospital. Child O died on June 23rd and Child P died on June 24th. Child O weighed 2.02 kilograms and was admitted to the neonatal unit. From about 5 p.m. on June 21st and through June 22nd, there was nothing remarkable about Child O's condition. Letby was on holiday from June 16th to 22nd, during which time she had gone to Ibiza. In text messages, Letby inquired with a male doctor about the triplets and said she felt at home in ITU, and the girls knew she was happy to be in room 1 of the neonatal unit. Child O was moved from room 1 to room 2 during June 22nd and was very stable, the court is told. Overnight on June 22nd to 23rd, Child O was recorded as having partially digested milk in aspirates, which was normal, and a stable night with a full abdomen at 7:30 am, showing no concern. Letby accepted that Child O was fine on June 22nd and the night of June 22nd to 23rd. She was the designated nurse for Child O and Child P on June 23rd, along with another baby, all in room 2. In police interview, Letby said the babies were in the high dependency room and the ratio should have been 1 nurse to 2 babies. Letby was the only designated nurse in room 2 for that day, plus supervision of student nurse Rebecca Morgan. Nurse Melanie Taylor confirmed there were no issues for Child O at the beginning of the shift. A doctor noted Child O's abdomen was full but not distended, soft, not tender, and he was making good progress at 9:30 am. Prior to the collapse of Child O, Melanie Taylor asked Letby if he should be moved to room 1 as he looked unwell. Letby did not agree and said he should stay in room 2. Melanie Taylor said she was put out by this. Lucy Letby, however, did not recall being dismissive. Letby recorded feeds for Child O at 10 am and noon. A note by a male doctor at 1:15 pm recorded a distended abdomen and a vomit after a feed and ordered an X-ray. Letby noted Child O, quote, reviewed by the registrar, had vomited undigested milk, tachycardic and abdomen distended. NG tube placed on free drainage. Saline bolus given as prescribed along with antibiotics. Placed nil by mouth and abdominal X-ray performed. Observations returned to normal. An entry on the blood gas record by Letby said Child O was on CPAP when he was not. Letby said she meant CPAP via Neopuff. Dr. Bowen said she could find no record of Child O being on CPAP for this time. In interview, Letby recalled Child O's abdomen becoming distended and him being intubated. She did not recall who was present when he vomited. Melanie Taylor said Child O collapsed at about 2:40 pm. When she went to nursery 2, Letby was already there and a doctor arrived after. Letby said she discovered the collapse after hearing his monitor alarming and he had a, quote, blotchy purpley red rash kind of mottling. She said mottling could be a sign of infection or cold. Child O was moved to nursery 1. The doctor's note of the event was a desaturation and bradycardia. He was mottled and the skin looked unusual. Child O was bagged and transferred to room 1. He was intubated at the first attempt and connected to a ventilator. The doctor went to speak to the parents. Letby noted Child O was, quote, mottled ++ with abdomen red, poor perfusion. She said she did nothing to Child O to introduce air and said 2 prescriptions on the neonatal schedule with her co-signature were for after the collapse. The doctor noted a, quote, very rare purpuric rash and good perfusion and Child O appeared to stabilise. Letby said she did not see the type of discoloration the doctor did. At 3:51 pm, Child O desaturated again to the 30s, quote, chest movement and air entry observed, minimal improvement. Doctors were crash called and Child O was reintubated on the first attempt. He had another desaturation at 4:15 p.m. and resuscitation efforts were made. There was no effective heartbeat and the abdomen was still distended. The rash had disappeared, which perplexed the doctor, who had not seen that kind of rash before or since. Care was withdrawn and Child O died. Dr. Breary said it was deeply distressing for all involved as Child O's deterioration came out of the blue and they excluded all natural causes. He later held a debrief at which he said Letby did not seem upset. Letby said she was shocked and upset at Child O's death, which was unexpected, and there was an element of delay when getting a registrar called to the room. She remembered Dr. Breary inserting a drain into Child O's abdomen which was swollen and red. She had not seen that procedure before. She said everyone was completely flat after Child O died. Child O's father described the stomach swelling up and looked like he had bad prickly heat, like you could see something oozing through his veins. Letby said she didn't see anything like that. A female doctor was quite upset and very apologetic at Child O's death and could not explain it. Dr. Breary told the court senior people at the hospital could not believe someone was trying to harm babies. He said there had been a meeting and when it was put to him about Letby's association with the events, he had said something along the lines of, "It can't be Lucy, not nice Lucy." He said senior clinicians were becoming increasingly concerned about the deaths. It was his opinion that there was not an increasing range of acuity of babies being treated and was wary it was a chicken and egg situation where because of the unexplained incidents that were happening on the unit, the baby's care needs became more acute. He said he wanted to escalate the situation properly in the hospital rather than by going to the police. He said Letby rejected his suggestion to take time off after Child O died. The Countess of Chester Hospital was redesignated as a Level 1 unit by its own decision on July 7, 2016. The number of cot spaces was reduced from 16 to 12, and the gestational age limit was raised from 27 weeks to 32. Dr. Kokai carried out a post-mortem examination. Dr. Marnarides reviewed and said injuries to the liver were the result of impact trauma. He said during treatment, small bruises could be caused to the surface of the liver and would not be extensive. He says the liver is not in an area where CPR is applied. He has only seen this kind of injury to the liver before in children, not babies, from accidents involving bicycles. He did not think CPR could produce this extensive injury. He also found internal gastric distension and concluded there had been an air embolus. Professor Arthurs also referred to radiograph images taken post-mortem. He said the gases were an unusual finding. Dr. Evans said the air was excessive and could have been administered via the NGT, and the skin discoloration was symptomatic of that. He said the bleed in the liver would also have contributed to the collapse. He could not find any evidence where the air embolus came accidentally. Dr. Bowen said the cause was excessive air down the stomach via the NGT, causing an air embolus, and could not see any innocent cause for that. She refuted the accusation from the defence that she was striving to support the case against Letby by supporting Dr. Evans. The prosecution say the jury can exclude natural causes and Letby caused deliberate harm to Child O. The defendant denies wrongdoing and the defence say it was a natural deterioration and the liver injury was caused during resuscitation. The judge refers to the case of Child P, born in very good health. At 10 a.m. on June 23rd, Dr. Cook recorded no concerns. Dr. Gibbs recorded Child P had active bowel sounds and a full, mildly distended abdomen. He said Child P appeared very well and should continue on NGT feeds, if there were any concerns for him to be fed intravenously. There was no suggestion of infection for Child P. Sophie Ellis was the designated nurse for Child P on June 23rd, 24th. She had learned that Child O had died on June 23rd. Child P's observations were in a normal area, and Sophie Ellis recorded a desaturation which resolved and a low-lying heart rate. For feeds, Child P was on 2 hourly feeds up to 8 p.m. on June 23rd with trace aspirates. At 8 p.m, Sophie Ellis aspirated 14 ml of milk with a pH of 3. She fed him a further 15 ml milk feed and placed him on his tummy. At midnight, a further 20 ml acidic milk aspirate was taken. Feeds were stopped and child P was put on 10% dextrose infusions. The last update on the night shift was abdomen soft and non-distended for child P. Nurse Catherine Percival Calderbank had said Letby found working there was boring and she tended to move back to the other nurseries, and colleagues were concerned for her mental health as those units could be distressing and exhausting. Letby in evidence said she never found nursery work boring and did not recall having a conversation with Catherine Percival Calderbank to say otherwise. In interview, Letby said she wanted to be designated nurse for child P that day to provide continuity of care. Full blood tests were ordered for child P. Dr. Yuko said child P was to be monitored as he had a distended abdomen. 20 minutes later, at around 9:50 am, child P desaturated. Rebecca Morgan said she recalled all the alarms going off and she helped Dr. Yuko taking the top of the incubator off. Dr. Yuko said he and Lucy Letby were in the room when child P collapsed. Arrow Park provided advice for treatment of child P. A poor blood gas result showed child P had respiratory acidosis. He had a poor heart rate and poor perfusion. Child P was sedated and paralysed, which Dr. Bowen said was entirely correct. At 11:30 am, child P desaturated again and he was given CPR. Spontaneous circulation was restored. A female doctor could not understand what was going on. Upon saying the transport team from Liverpool were arriving to transfer child P, Letby had said words to the effect of, "He's not leaving here alive, is he?" The female doctor replied, "Don't say that." She thought they were doing well at that point. In evidence, Letby said she could potentially have said that at the time, and that both she and the female doctor were both stressed. Letby said from her recollection there was no reference to a tube dislodging for child P. There is no evidence of anyone checking if it was blocked when it was removed. A radiograph image taken at 11:57 am had showed a pneumothorax, which was not a tension pneumothorax. A male doctor's recollection from 12:50 pm was that it was very busy for child P and the plan was to insert a chest drain. There was no apparent cause for what was going on clinically, the judge tells the court. Letby said she recalled the pneumothorax and there was a general decline for child P. A miscalculation had been made where the adrenaline doses were higher than they should have been, but a doctor from the transport team had previously told the court that they found no sign of child P being impacted by that. Child P's mother said child P's stomach looked the same but not as swollen. The father said the scene in the unit was one of pandemonium. A female doctor was very apologetic to them, saying they would get to the bottom of what had caused the collapses. The third triplet, who was stable, was taken to Liverpool by the transport team. In evidence, Letby said she had been involved with administering a lot of medication and did not recall seeing any discoloration. She said there was relief on the unit when the transport team turned up. She said there was discussion if there had been a bug on the unit. After the deaths of child O and child P, the consultants insisted Lucy Letby was removed from the unit and resisted attempts to bring her back, the court is told. Dr. Marnarides said he had no evidence to indicate a natural disease that would account for child P's death. He thought small hematomas to the liver were potentially the result of CPR or as a result of prematurity, and did not have enough to say it was an impact injury. He said there was no clinical evidence for a natural cause. He said having considered other accounts, he concluded there was gastric distension caused by excessive air injected into the stomach. Professor Arthurs reviewed radiographic images for child P. He said the gases shown were unusual for a baby who did not have natural diseases. He said it was consistent with air administered. Dr. Evans was at a loss to explain how child P had collapsed. He had believed the cause was complications from the pneumothorax. There was no credible natural cause. In cross-examination, he said an experienced or competent nurse or doctor would not cause a liver injury in resuscitations. He said child P could have collapsed from doses of air administered and denied shifting his account to fit the evidence. Dr. Bowen was concerned about the X-ray for child P on the night of June 23rd and the air present. Overnight, child P became intolerant of feeds. She said attention should have been paid to the X-ray, which showed a pneumothorax earlier. She said the air in child P's abdomen from the night before was abnormal and had been introduced at some point or points via the NGT, splinting the diaphragm. She could not think of any natural occurring phenomena that accounted for the subsequent collapses. The judge now refers to the case of child Q, a baby boy born on June 22, 2016 at the Countess of Chester Hospital. He weighed 2,076 grams at birth and required breathing support. He was taken to the neonatal unit. The judge says there were no signs of infection. 3 days later, on June 25th, child Q had a profound desaturation and vomit. The prosecution say this was liquid and possibly air being forced down the NGT. They say possible mild NEC would not account for the type of desaturation and recovery. The defence say developing NEC cannot be excluded. For June 23rd to 24th, Tanya Downs was designated nurse for child Q. She noted coffee ground style amounts of bile in child Q. 1.5 ml of bile was aspirated at 4 AM. The nurse recalled child Q had to be readmitted in July 2016 with gut problems at the out of hours clinic. Letby noted, quote, 0910 child Q attended by senior nurse Lapalainen. He had vomited clear fluid nasally from mouth. Desaturation and bradycardia, mottled ++. Neopuff and suction applied. Registrar attended. Air ++ aspirated from NG tube. Letby said in police interview she had returned to nursery 2 to see child Q being tended to by nurse Lapalainen. When asked about the air in child Q's stomach, she said sometimes babies gulp when they vomit and there could have been a blockage in the bowel. She said she would not have left room 2 if child Q was not stable. She denied causing child Q harm or leaving the room, so she had an alibi for the incident. In evidence, she said child Q had a low temperature and was concerned about that. She said she arranged with nurses Lapalainen and Griffith for when she went to nursery 1 and was there for a few minutes. For the 9 AM feed for child Q, the oxygen and saturation levels are missing. She said those omissions were a mistake. She said the baby in room 1 was an intensive care baby, so she could not leave that baby for very long. She said she had no part in giving Neopuff after child Q needed oxygen. She said she was told air ++ had been aspirated from the NG tube. She said the collapse, relatively speaking, was not serious. A male doctor was called to the unit. He noted as a result of the neopuffing, child Q's saturations returned to 100%. The baby was moved to room 1 and put on CPAP and given antibiotics as a precaution. He was presumed at this time to have sepsis. A blood test could not give a reason for the vomit, the judge says. A chest x-ray showed a trace fluid and no suggestion of a large amount of foreign matter or a sign of infection. Dr. John Gibbs said the collapse did not fit with a baby who was tired. It was decided to intubate child Q and put him on a ventilator. A female doctor examined child Q, noted the blood gases were acceptable. Child Q was very unsettled at times, but there were no signs of concern, she recalled. She saw a sign of respiratory acidosis and the ventilator settings were changed. Amy Davies said child Q was restless at times. On June 26th, child Q showed a loop in the bowel. Arrangements were made to transfer child Q to Alderhay Children's Hospital. A consultant there stated in agreed evidence that child Q had been admitted due to concerns over his deteriorating condition. When assessed, child Q was stable and his abdomen very slightly swollen. By the night of June 26th, he was assessed as very stable with subtle signs of NEC and was taken off the ventilator by June 27th. The decision was made to transfer child Q back to the Countess of Chester Hospital on June 28th. Dr. Evans and Dr. Bowen had considered the possibility of NEC. Dr. Evans said although there were markers of child Q having infection from the bile aspirates and not really tolerating feeds, it did not explain the sudden collapse at 9:10 AM with a very significant deterioration. It was not clear how to put it all together. He said child Q would not have vomited anything at all unless a lot of clear fluid had been forced down the NGT, possibly with air as well. He said once child Q had vomited, he recovered. He said in relation to the air +++, there was very little neopuffing taking place. He said when babies vomit, they do not swallow air. In cross-examination, he accepted he had initially concluded child Q had received air and not fluid. The air ++ was, quote, noteworthy. Dr. Evans refuted he had added the liquid element to support the case. He said the evidence he had heard from the people looking after child Q had been a great help in forming his opinion. He said the presence of NEC or otherwise could not be discounted, but that would not cause a sudden collapse, and noted the rapid recovery of child Q and no further gastrointestinal problems until his discharge from the Countess of Chester Hospital in July 2016. Dr. Bowen noted that aspirates were not uncommon for child Q prior to the collapse. She did not know where the fluid +++ came from for child Q from the notes. Child Q's intermittent air was unlikely to cause the, quote, air ++ aspirated. She concluded child Q had been given air down the NG tube, which had distended the abdomen so much, squashing the lungs, causing mottling. In cross-examination, she agreed mucus +++ being aspirated could cause problems with breathing. She said there was not a cause of where the mucus +++ would have come from. She refuted the possibility of any baby sucking in air during a vomit. She added aspirates was a sign of NEC as well as other factors. She said it was not a diagnosis of NEC. She said child Q got better too quickly for it to have been mild NEC. After Letby was taken off nursing duties, she filed a grievance with the hospital in September 2016. She said that time was emotionally difficult and had left her feeling isolated. The judge says searches of Letby's home in Chester and Hereford were carried out in 2018 and 2019 respectively. He said there were various papers collected, including, quote, not good enough and I am a horrible, evil person. The defence says these were notes written by someone who was distraught at what was happening and was being unfairly targeted. The prosecution say the notes are by a troubled person who was in part confessing to what she had done. 257 handover sheets were found at Letby's Chester and Hereford homes, 21 of which in relation to babies in the indictment. In relation to a note filled in on both sides, Letby said she had written it as, quote, everything had got on top of her and it made her feel guilty and isolated and she was blaming herself. She thought the police would be involved and she would lose her job. She thought she was being victimised by Dr. Ravi Jairam and Dr. Stephen Breary. She said despite what she had written, she had not killed them on purpose. She said she was career focused, and the note I am evil I did this was how the situation had made her feel. She said that year was difficult as there were more babies being admitted to the neonatal unit with more complex needs such as chest drains and stomas. Staffing levels were quite poor at times and she was doing a lot of additional shifts and overtime and did not believe there was much support on offer. She said the handover sheets she had taken home in her pocket were kept for no particular reason and she did not know how to dispose of them. Letby had said ideally handover sheets should be put in the confidential waste bin. She said she hardly ever looked at them. In evidence, she confirmed she bought a shredder and only shredded bank statements. The handover sheets and notes were insignificant. When asked about Child M's blood gas records, the note taken home was an error on her part and said the sheets had no meaning to her. In a 2019 police interview, she identified a support network of 3 nurses and a doctor that she had after being removed from nursing duties. She had said she was not really aware of air embolisms and could not recall any specific training in that. In her 2020 interview, Letby was asked about the diaries. She said she thought she started documenting names amid concerns of the rising number of babies dying. In evidence, she said she had liked all the doctors at the hospital. She said she was worried she was in trouble as she may have made a mistake in the care of child Q. She accepted in an email she had written she was having a, quote, ++ meltdown. In messages to a colleague, she accepted reference had been made to air embolus and had filled a Datix form on July 1, 2016, in which she cited an open port had a potential risk of air embolus. She denied she was covering herself for a cause of accidental air embolus. The judge says the jurors have to be sure of the defendant's guilt, her character and any inconsistencies between evidence given by the defendant and any witnesses. The judge says if jurors are sure that 2 babies had insulin administered to them deliberately, they have to consider whether that was a coincidence or whether it was done by one person, and if so, who. He says there were common features among the cases, that the defendant was on duty for each event. He refers to the note that Nicholas Johnson had made, which was a list that included 5 babies had unusual bleeding, 8 had discoloration. The defendant said she did not see discoloration, or there was no discoloration to be seen. 5 babies' collapses happened within moments of a nurse going on break. 4 of the babies were screaming, crying uncharacteristically. 4 babies recovered after being taken to another hospital. 3 cases were where Letby was accused of behaving inappropriately after the baby passed away. The prosecution say these are not unconnected events and say that insulin, air embolus and post-mortem findings can make the jury sure of Letby's guilt. Letby denies doing any harm, and the searches and keeping of confidential documents had nothing sinister. The handwritten notes were a product of despair. The defence say the jury cannot be sure in any event of Letby's guilt.